The next step is going to be the PR interval. We measure the interval from the beginning of the P wave to the beginning of the QRS complex, so the beginning of the Q wave. Now, this interval basically equates to the time interval between the activation of the atria and the activation of the ventricles. An easy way of saying that it's normal is finding out the PR interval, and if it's less than 200 milliseconds, or one big square. If it's greater, then it's going to be called a first-degree heart block. When we're evaluating heart blocks in general, we always need to think about the rate and the associated symptoms. A profound first-degree AV block can lead to fatigue and shortness of breath. This is because the PR interval is so long that the synchrony between the atria and the ventricles is eventually lost, and this can have a consequence on cardiac output. This would typically be around 300 milliseconds or more. Generally, first-degree heart blocks are asymptomatic and they're not concerning for progression to a higher degree AV block. One of the common causes is a block due to increased vagal tone. You typically see this in young athletes, especially long-distance runners. But for a profound first-degree heart block, so 300 milliseconds or more, that could be due to Lenigre's disease, which is the fibrosis of the conduction system, typically occurs in elderly patients. It could also be a result of ischemic heart disease. It may occur in an inferior myocardial infarction where you have the occlusion of the right coronary artery. And also cardiomyopathies like HOCM, hypertrophic obstructive cardiomyopathy, like sarcoidosis. As you can see, there's many causes. Medications is also an important one. Beta blockers, calcium channel blockers, and digoxin. And finally, we just have an example of a short PR interval, which is less than 120 milliseconds. And this should raise concern for a pre-excitation syndrome like WPW, Wolff-Parkinson-White syndrome.